you very much. I'm going to pick up on a whole lot of themes that have already come across, and I don't pretend to have the answers to how we are going to move to integrating HIV and SRH services, but I hope that I'll leave some food for thought and some questions as we talk in the next 20 minutes. I'd like to thank Elona and the team and Shalom for actually inviting me to give this talk. So thank you very much, both of you, and to the organizers. The big one. Oh, right. Okay. See, technology is not my forte. So, when we talk about integrated services, what do we really mean? And there is a very basic definition, which is essentially different kinds of sexual and reproductive health services and HIV services, or programs that can be joined together to ensure that we perhaps maximize collective outcomes. And this is overall based on the need to offer comprehensive services. Now, you'll all recognize from this that this is a very high-level definition, and the real devil is in the detail. We also all know, and I think if I asked all of you, we would all say that integrated HIV and SRH services are a good thing. And what is the rationale? Well, it increases access to and uptake of services. It improves potentially client and staff satisfaction. And after all, we are all talking about person-centeredness now, and potentially efficiency, because you get improved coverage. Potentially, you reduce the cost because you're providing services through one channel, and you potentially reduce costs to not just services, but also to users, and ultimately improve SRH and HIV rights and outcomes. Great. So it all sounds like a complete no-brainer. But it is a lot harder than it sounds. And why is it so hard? Because we are, as we've heard across this conference workshop has come out, is that, we are really programming and delivering services through a very vertical siloed approach. We have family planning programs, HIV testing, PrEP programs or prevention programs, and VMMC, and I could go on and on. So, we've traditionally been structured, and a lot of healthcare services have been structured as siloed vertical programs with very distinct funding channels coming through. So, for example, the TB funding will come this way, and the HIV funding will come this way, and yet we are talking about now delivering services through one funnel. So that will need a lot of political will. Is that present? It will need buy-in from funders, which is intricately linked to politics. And what importantly it will need, and what I want you to focus on today, is what is the definition and level of integration? What do we really mean when we talk about definition? And importantly, while we all say it's a good thing, without to change political will and to change programming, the way we're going to be able to do it is if we produce evidence of feasibility and really demonstrate that it works and it's feasible on the ground. It's acceptable to both the individuals who deliver services, but also individuals who access the services, and whether it's cost effective. So these are some of the questions that arise, and I don't have the answers to them, but these are the things that we need to think about when we think of configuring integrated services, right? What does it mean to you when you talk about integration? And this is important because what we are going to need to do as in the years and months and years going forward, particularly as we are in the era of universal health coverage, is think about what is going to work in your context with respect to integrated services. And the setting, our services, the SRH and HIV services, are you going to deliver them in a primary healthcare clinic? Are you going to deliver them in an HIV clinic? Is it going to be in a standalone center? Is it going to be in educational institutions like colleges or schools? Is it going to be in community-based settings? Where are the services going to be delivered? Who is going to deliver them? Is it going to be a nurse? Is it going to be a doctor? Is it going to be counselors? Is it going to be community health workers? Different people are engaged in delivering different sorts of services. So what configuration of a team do you need? And then, really importantly, when we talk about integration, what services are you actually talking about integrating? When we talk about HIV, are you talking about testing? Are you talking about delivery of antiretroviral therapy? Are you talking about initiation and then passing them on somewhere else for delivery? Are you talking about prevention? And prevention is not one thing. Is it PrEP? Is it PEP? Is it condoms? Is it VMMC? Voluntary medical male circumcision. That's just an example. Are you going to combine, or are you going to have a combination of the various aspects of prevention and care? When we talk about sexual and reproductive health, again, what do we really mean? Do we think about family planning? And if we do we mean about providing information and counseling, or do we need to provide commodities too? If we do, what commodities we're talking about? And I appreciate I'm talking a lot of detail, but this is because, we've recently conducted a trial, and these are the questions we grappled with, and I'll show you a little bit of stuff around that. But, for example, where I work in Zimbabwe, we've got Population Services Zimbabwe that has a program for coming to deliver LARCs. They'll come and do implants in the community. That's not really what I would see as family planning per se, but it is an important component of delivering family planning. Menstrual health management, STI management, hepatitis B and C, particularly as we move into the era of triple elimination, HPV vaccines and cervical screening, intimate partner violence, sexual assault. Do you do pregnancy services? And then very importantly, we heard colleague talk on the first day of a really neglected area around non-communicable diseases. We heard Terry talk yesterday about mental health. These are, of course, all components of providing healthcare that are not siloed off from SRH. And we heard from Teresa and others that, SRH and mental health are not delinked. Is that part of providing SRH services? Importantly, are we talking about providing information and counseling only? Are we talking about raising awareness only, or sensitization, or engagement, or mobilization? You're talking about providing commodities. And certain provisions will require a nurse or a doctor, and certain provision will not require that level of a healthcare provider. So we need to be thinking about all of those when we talk about integration of services. Oh, I beg your pardon. Okay, oh shoot. I'm really sorry. I'm going to move on to this video, which talks about the trial that we did.
In Zimbabwe, HIV infection is a leading cause of death amongst youth. Youth are less likely to be able to access HIV testing. Among those diagnosed, antiretroviral therapy coverage and adherence is lower than in any other age group. This results in worse outcomes. We also know that young people encounter personal, sociocultural, legal, and structural barriers to accessing HIV and other essential health services. We conducted a cluster randomized trial called CHIEDZA, which stands for Community-Based Interventions to Improve HIV Outcomes in Youth. The trial aimed to investigate the impact of providing an integrated package of HIV and sexual reproductive health services in a community-based setting for youth on HIV outcomes. CHIEDZA was conducted in 3 provinces of Zimbabwe, with each province having 8 clusters. A cluster was a geographically defined area in a community. Clusters were randomized to receiving the CHIEDZA service package, called the intervention arm, or to a standard of care that is existing services, called the control arm. Services were offered once a week from a community center in the intervention cluster by a multidisciplinary team of CHIEDZA nurses, community health workers, youth workers, and counselors over 30 months. The CHIEDZA intervention was offered to youth aged 16 to 24 years resident in the intervention clusters. The package of services we offered included HIV testing, initiation of antiretroviral therapy, and follow-up treatment and adherence support, including CAPS groups, which were treatment support groups for youth living with HIV. In addition, we offered contraception, specially designed condoms, management of STIs, menstrual health education and products, and general health counseling. Referral to additional health services were also offered to participants as needed. We are providing information and education on menstrual health, as well as a choice of menstrual products, the period pants, reusable pads, and the menstrual cup. And what we've seen in Chiedza is there's a huge unmet need for menstrual health. So we have a lot of young women coming to Chiedza for menstrual health, but that allows us to engage in a conversation about reproductive health and then talk to them about getting tested for HIV or STIs or even getting onto contraception.
The trial has several innovative aspects. Firstly, there is an active strategy for engaging youth in both the design, delivery, and evaluation of the intervention.
What we've done is we've created a package of services in the community for young people. We've packaged them in such a way that they're fun, they're vibrant, they're in spaces where young people want to be, they're spaces where young people can interact with each other. While young people are in the spaces, they can also access services. And so we set up booths within the youth centers where if a young person is playing pool, for example, they can also step away from their friends and get an HIV test. They can step away from their friends and speak to somebody like a counselor about relationship problems or any substance abuse issues they might be having.
The trial will conduct a detailed process evaluation and also a cost-effectiveness study to inform scalability should the intervention prove effective.
The trial outcomes for both Chiedza and STEPS will be ascertained at population level by conducting a community-based survey of 16,800 youths across the study intervention and control clusters.
The survey will provide an opportunity at investigating a number of important health behaviors and outcomes among young people. These include smoking and alcohol use, drug use, as well as mental health and family planning. This will be the largest survey of youth in sub-Saharan Africa. The reason I showed you that video is because, because I put a lot of questions in front of you in terms of all the things of where, how, and we trialed one. And these were some of the services we offered, that included both SRH and HIV services. And really, I think the point I want to make is how long it took us to, really sort of talk to young people and figure out what services they wanted versus what was feasible and versus what we could do and what was real in our setting. And I'm just presenting this data for women because women were our majority of our clients. But what this shows is that only a minority took one service. The median number of services people took was 2.4. So people will really use one service as a hook to access another. And one of the key lessons I learned is that actually, whilst programmers and people like me, our trial outcome was HIV viral load suppression, because that's kind of what partly gets funded. But my interest was to try to kind of understand that we had heard time and time again that young people HIV testing is not necessarily a priority, but the priority was, for example, menstrual testing, menstrual health, and then that could serve as a hook. So there were a lot of key ingredients for acceptability that we heard about, and I want to share some of those with you for when we are going to provide or when we provide services, and particularly integrated services. It's really important that services and commodities are free of cost. And whilst HIV treatment is free, many of the SRH commodities, and I don't mean, when I say commodities, I mean the pills, and I mean the injections, and I mean the menstrual cup being free of cost, and particularly menstrual products. They need to be easy to access, and we heard in the previous session that you can have services available, but they need to be where young people can get to them. And very importantly, the environment. It needs to be a space where being young is celebrated and not sanctioned. And again, we've heard that again and again, that you have to justify who you are as a young person and be labeled for having, being sexually active. And one of the key things that came out when you provided integrated services is the providers are absolutely critical wherever you deliver them. They need to see the client as a whole person. So very often we go to a clinic where you have HIV services, people are carrying their red book or yellow book and green book. In Zimbabwe, for instance, you're labeled as a person who's kind of from the HIV program. So you go in and then the provider will talk to you about your HIV treatment, why you haven't taken drug, rather than the fact that you're a person whose interest might not be the HIV treatment. Yes, you need it, but your concern might be the fact that you want condoms or prevent pregnancy at this point in your life. And then the fact that you can have open conversations about health in its broadest context, so that you're, for a young person, very much that, sometimes I just want to talk about my relationship or, my partner or what's happening at home. And that also is part of well-being and not taking health in its broadest terms. And then obviously the really valuing client privacy, confidentiality, and respect, and not just saying that, but actually manifesting them. Not calling out people's names in public, remembering to sort of not wave people's prescriptions in the air, or it's how you actually work it. And then again, hearing what has been said, choice. People want choice. And the value of integration is often realized once clients access a service. And that is that some service components act as a hook for others and promote uptake of services that may otherwise be less a priority. And that was something that we really came out loud and clear. So the other lessons we learned, which were very hard, and I think we need to take that with us when we think about integration, is, as well as acceptability, and I talked about some of the factors, we need to be thinking about affordability, both for programs, but also, as I said, for the service users, and that's why the free of cost services matter, and accessibility. And we found that even if services were 1 kilometer or 2 kilometers away, the uptake decreases and was very strongly correlated with distance from services. And that need to be strategies in place to overcome barriers to uptake, use, and continued engagement. And these are at various levels: individual, interpersonal, community, and societal. And programs will have to pay a lot of attention to overcome those, because the way health systems are structured, funders are structured, the way providers are structured, the way we, as many of us are providers, are structured, is that we like to think about our priority. And those need to be really broken down. The quality and efficiency of services really matter. So if one is going to go into having lots of services accessed, then one needs to think about the infrastructure, the staffing, as I alluded to earlier, the flow of service, and really managing the robust supply of commodities. Because you're not just thinking of one thing in your program, you're thinking of multiple things that you need to take care of. And the moment those are not right, trust is lost. And one of the things I've learned in my 25 years of working with young people is that trust is very precious. It's not given easily. And if we want to win it, we have to work really hard to get that right. And we, of course, need to train providers on addressing the needs of sexually diverse communities. So it's not just for cisgender individuals, but really thinking about not compartmentalizing young people. Again, thinking about also key populations that we heard about earlier. The other important aspect is that whenever we think about delivering a number of different services, this automatically will mean linkages with stakeholders and involvement of end beneficiaries. And this comes back to a point I wanted to make. Unfortunately, I overstepped on the slide, is what does integration really mean in terms of, is a starting point the HIV clinic and we are adding services onto a HIV clinic, or is the starting point the primary care clinic and we are adding HIV services on it? We really need to be thinking about, or is it that no services exist and we provide everything together? Because I'm sure that most of you, while you're delivering services, will have a starting point where you want to build from. And those are not always set up to deliver everything. And defining what is a linkage versus what is a delivery. What I mean by that is that some services you may not be able to deliver there and there on site, and you will have to link to other providers. So for example, if you're doing SRH services, are you also going to be doing the VMMC there, or are you going to send them to have circumcision done? So, does that mean integration for a young person if they have to go somewhere else? So really defining the level of integration and, are we talking about the level at the program level where it's funding, or for a young person, it means that I go somewhere and I get my service? Do I get my service from the same provider, or do I get it from a provider and then I have to walk a distance, or I might even have to go to a new facility, even if there's an expedited linkage? So inevitably, linkages with stakeholders will need to be there, and those need to be very critically defined and laid out so that referral pathways, if they need to happen, are clear and unfettered. And I don't need to tell this audience that involvement and centering the voice of end beneficiaries so we know what services are desired, how they want to get them, etc., is absolutely critical. And we learned very early on that, when we designed CHETSA, that we really didn't know what to do until our young people told us that this is acceptable, this is not going to be acceptable, the spaces you design are really boring, it matters to us what the space looks like. And we ended up investing. I'm a really boring scientist, can't pretend to be a young person. So, we ended up investing a lot in making spaces attractive. And ultimately, overall investment in health systems and laws will have to follow, but it will follow from ground up. Once the audience here and people who are on the ground really sit down and thoughtfully work out how they are going to integrate in their context. And so CHETSA Light, I think need to be careful about distance from services. Important that we had low population level coverage from those at risk. And so, particularly males. So generating youth demand and configuring it to take care of services and providers is really critical. And you work out what that configuration is going to look like. So in conclusion, no one size will fit all, and context really matters. And what I leave you with is really there's a really critical gap here for implementation research to identify strategies for integration in different health systems and social contexts that will lead to ultimately better uptake. And you need to define at the outset the parameters of integration. And underlying all of that, addressing barriers to engagement with services remains critical. Thank you very much.